Yeah, I think I've got the screen now. So thank you very much for the opportunity to talk about these guidelines. It's been an interesting process. Took a few years to get there. I'll start off by saying neither my wife nor I have any conflict of interests that would need to be notified of. Um, so I went ahead. Sorry, would you mind to back up one slide? I don't have that. Yeah. So the objectives are really two. One is to explain why the annual TB testing we've done for years is really not an effective strategy at preventing TB morbidity and mortality among U.S. healthcare personnel. And most of this discussion, I will refer to these as HCP or healthcare personnel. The idea here being to include not only healthcare workers who are paid, but also like volunteers and other people who may be in the healthcare setting who may not be actually working or being paid to work. And the idea is that individuals, all of us should be able to advocate for changing the policy in our own settings. The second objective is to describe why most of the annual testing done in recent years that has produced positive skin tests and positive IgRAs, that most of those are really false positive reactions, and be able to apply that information to say, this is why we should be doing things differently in our institution, and this is how we should address a new positive result in an individual in our healthcare facility. So I want to give a couple of presentations. I actually presented these back in 2014 at the Association of Occupational Healthcare Providers. So the first one is a 34-year-old woman who was working as a healthcare provider, an LPN at a long-term care facility in Denver, and she was diagnosed with pneumonia. She had no history of a skin test ever being done. She had a persistent cough over 13 months and had been diagnosed with this left-sided pneumonia you can see on this chest x-ray 11 months earlier. Now, she actually got better with a course of moxifloxacin, but it came back, so she was treated twice more. And then the physicians finally decided, well, let's do an evaluation to see why this pneumonia is recurring. A bronchoscopy was done, and I don't know whether this was just a routine, let's check everything and we'll get an AFB, but anyway, it was smear negative, but grew Mycobacterium tuberculosis. By the time this culture came back, they brought her in, got a sputum, it was rare, AFB positive, and pan susceptible. So her history is that she was born in a TB high burden country, arrived after a normal pre-departure x-ray about 3 years earlier. She was now 12 weeks pregnant. She denied weight loss, had a minimal cough now after her last course of moxifloxacin. She was working, and when her primary care provider said, you need to go immediately to the hospital, she said, I can't do that. I've got a job. I need to be at work. They reported her to the health department. We had her come in for outpatient evaluation and treatment. And fortunately, there was really no transmission we detected. She even had a toddler in her home and her husband who were negative on IgRA testing. And here's what her film looked like pre-bronchoscopy, very similar to the earlier film. Now, the second case I want to mention is a nursing student. And she had referred herself to a hospital here in town that specializes in lung diseases, and got an appointment about a month later. She ended up with a Friday afternoon appointment, was sent for an x-ray, then got a call when she got home and said, you know, it looks like you probably have TB, so you need to go to Denver Public Health on Monday when the clinic opens up. She came in, her smear was 3+ positive. You can see the cavity in her right apex. And she had traveled all around South Africa in 2006, including KwaZulu-Natal. So we were quite worried about what kind of TB she would have, but it turned out it was pan susceptible with rapid molecular testing being done. The story for her is 5 months of coughing. She had been treated twice for bronchitis with 2 antibiotics without TB activity, fortunately. or maybe unfortunately, who knows? The skin test was placed and read as negative, although she said, there was some redness there that I had questions about. During this long call, she asked the student health service, she said, do you think I could have tuberculosis? I lived in South Africa for 6 months during college. The answer was, no, this is just bronchitis. No chest x-ray done. Unfortunately, she did have a TB case that was infectious, and 17% of her 121 contacts at both the restaurant where she worked, as well as the nursing school, including students and faculty members, ended up with a positive quantiferon test. This turned out to be a very useful study. This was done by colleagues at the CDC, Lauren Lambert, the lead author. So this covers a 13-year period of data, and later on we'll see a 7-year period of actual, or a 5-year period where there were rates available. But this is a comparison of all other adults in the US during this period with healthcare workers. And overall, 3% of the cases were among healthcare workers. As you can see and would expect, they're more likely to be female, a bit younger. They were actually more likely to be foreign-born. They were more likely to be from the Philippines, India, and Haiti. A little bit more resistant to INH, but not much. A little more likely to have MDR-TB. A younger, healthy working population in general. So postmortem diagnoses were less than 1%, although there were 52 of those over this period. And 134 died on treatment. Now, we often wonder, well, were these people who died with TB or of TB? But around 14 a year, you figure maybe at least 10 of those might have really died of TB. I also point out that a lot of these were early after arrival diagnoses, 7% within 6 months of arrival, and 18% within a year. And this is the period for which rates were available. And again, this is a 5-year period. And what they were able to do is to get the denominators of healthcare workers by birthplace as well as the TB cases. And as you know, most of the, as you might expect, most of the the healthcare workers were US born, 1.8 million males and 7 million females. Their rates were 2.3 and 1.6. The foreign-born were a smaller population of about 400,000 males with a rate of 21 and 1.1 million females with a rate of 16.6. Now, during this 5-year period, the healthcare worker rate overall was 4.2 per 100,000 per year. And the national rates during that period dropped from 5.1 to 4.4. So the rates are always lower among the US born healthcare workers than in other adults. So again, providing some clear indications that there's no evidence in rates that TB is a high risk issue for US healthcare workers today. And this period, as you know, was really right after the recurrence of TB in the late 80s and the early 90s. So the conclusions, I and Wendy Tanasi, who was also at this conference in New Orleans, were that healthcare workers only account for about 3 to 4% of the cases, but these numbers range 300 to 400 a year. There's no evidence of occupational risk as a cause of these cases. And we knew from institutions looking at their annual conversion rates during skin testing that most institutions were now seeing less than 1% per year annual conversion rates. And we really think that majority of TB, as in the 2 examples I gave you, were really from exposure and infection that occurred outside of the healthcare setting, or maybe in healthcare settings in other countries before the person moved here. There probably are some from travel, like our young lady, but the risk overall is probably fairly low. And so among the foreign-born healthcare workers, it seemed like a lot of these were likely imported, which points to the importance of screening new arrivals and new workers. And a majority of cases and deaths and the risk for transmission from healthcare workers is really potentially preventable, not by more targeted testing, but targeted testing and treatment for latent TB infection. The other challenge is that since the rate is so low in most healthcare workers, except those with known exposures, how well do our skin tests and IGRAs perform in a population with a low prior probability of true infection? Well, we know any test in that setting, unless it's 100% specific and none are, you're going to see an increase in the frequency of false positives and your positive predictive value. In other words, the likelihood that a positive is a true positive is going to fall off. And the question is, how can we use these tests, given their limitations, to most efficiently prevent TB among healthcare workers and transmission to other staff members and patients, as well as their households? I'll just show you a little bit of data from the TBSC healthcare worker study. This was 4 institutions, and these healthcare workers had a negative baseline, and as a part of the study had all 3 tests repeated every 6 months. Well, this conversion rate during this period of repeat testing with the skin test was 0.9%. And most of these were not positive to any other test at all. And of those individuals willing to have it repeated, reversion was seen in 91.7%. Unfortunately, the IGRAs had a much higher cumulative conversion rate after 3 tests and a similar high reversion rate. So again, just an indication, these are individuals that are not getting TB infection based on skin test data and finding cases in our hospitals among healthcare providers, and yet we're getting these conversion rates that are really unacceptable. So just in sort of summary, again, these tests really measure cell-mediated immunity through different methods for the skin test and the IGRAs. And again, with all diagnostic tests, one can expect that the positive predictive value is going to be low in settings where you're testing people who, most of whom do not have true infection. And this would include most US healthcare workers getting an annual test, most travelers and medical volunteers with a conversion. Nice study in Holland where they looked at that, and individuals, unless they actually worked intensively in a medical setting abroad during their several months overseas, when they're retested, they usually have a negative test. And then of those with medical risk, in other words, their risk for progression is high, but their risk of exposure is low, a lot of these are going to be false positive. It creates a conundrum of who do you treat based on these results? And at least in our HIV clinics in Denver, we're very comfortable with our really low-risk population of US-born healthcare HIV clinic clientele. Is just, if we get a positive, we repeat it. If it's negative, we say, you know, we're really comfortable calling that a false positive that you had the first time. Not every situation would be the same. And so the conclusion Wendy and I had was in 2014, it's time to stop doing so much routine annual testing. And we discussed the pros and cons of that and discussed the need to really collaborate with these occupational health providers in trying to make some changes in these recommendations. So here's a timeline for the transition. So again, this conference in New Orleans in 2014 that Wendy and I were at, the next year, Bob and Wendy showed up in San Francisco with the same Association of Occupational Health Professionals. And then out of that, developed a work group of individuals, both at the NTCA and the CDC, to look at revisions. And this was done after conducting a systematic review of the post-2005 publications using the Guide for Community Preventive Services for drafting a revised guideline. And the initial draft, and this was headed up by Lynn Sosa in Connecticut, this was presented in initial and revised drafts to both ASAT, the Advisory Council for Elimination of TB, HICPAC of Infection Control Practitioners, and the NTCA National Conference. And then in May of 2019, there was an MDR I'm sorry, MMWR publication provided a fairly short and to the point with not a lot of details. And the idea was that there would be a companion document developed, and a work group had already been formed for that to really fill in the details that wouldn't be amenable to the type of review done for the documentation, but would be useful for implementation. And this group, again, started meeting in 2018, and finally in July of this year in 2020, the American College of Occupational and Environmental Medicine group, which collaborated with the NTCA on this, produced this publication in their journal. And this is a bit more of an academic group. They had their own journal, and so it made sense to work with them rather than AOHP. Okay, so here's just some of the copies of the materials from the MMWR in May of 2019. The authors, again, you can see Lynn Sosa as the lead. And just very quickly, I'll mention the 2005 guidelines and a comparison of those with 2019. So the issue of baseline, or what occupational health providers call pre-placement screening and testing, is pretty much unchanged. What's different is that each healthcare provider should have their own individual risk assessment documented so that the providers can say, oh, you have no risk factors at all. We know how to interpret your test. If it's positive, it's probably a false positive. Or, oh, you lived in a high burden country for 5 years and worked in a hospital. We know how to interpret your test. If it's positive, we're going to consider it positive. So that's a key difference for that issue. In terms of post-exposure screening and testing, again, this is all pretty much unchanged. Get a good baseline, repeat in 8 weeks if negative, if there's a documented exposure. For serial screening and testing of healthcare providers without LTBI, it's really not routinely recommended now. So that's a big change. Even in hospitals that see a fair number of cases, as was considered a criteria in the past. Also, an encouragement for annual TB education of healthcare providers, that's unchanged. What's different is a new emphasis on the issue of exposure, whether it's in the hospital setting, at home, during travel, other work, saying this is an important new issue to address. In terms of evaluation and treatment, in the past, it was referred to a provider regarding the need for LTBI treatment. And we know in many institutions, the healthcare, occupational health program would really have no idea whoever made the referral, kept the referral, took treatment, et cetera. The emphasis now is these cases of TB occurring in our healthcare settings put the healthcare workers at risk themselves, in addition to their family members, in addition to their colleagues, in addition to patients. And we really need to ensure that the healthcare providers who are truly infected know their risk, that this is something they can address, and encourage treatment to occur. So that's a big change in this document. I'll show you a couple of boxes, and this is just the issue of risk assessment. It doesn't need to be complicated. And this is basically sort of derived from the California screening tool, which basically says, if you've lived in a country where TB is common, and it's easier to say which countries that's not, the United States, Australia, Canada, New Zealand, and so forth, than it is to list all the countries where TB is more common. The second risk factor is the risk factor for progression. And again, that doesn't necessarily track with exposure at all. And then close contact, a very important one, as we all know. So those are the simplified version of a risk assessment that healthcare providers should be familiar with. Okay, so this is a document that just came out last month. It's 15 pages. So you might say, my gosh, what's it need to be so big for? Well, these occupational health providers, they didn't want to say, okay, if you want to know about testing, go see the David Lewinson article in the American Journal of Respiratory and Critical Care Medicine, where it talks about TB diagnostics. If you want to hear about the regimens we use, go to this other journal and pull those up. They said, we want everything that the healthcare, occupational healthcare providers need in one location and so forth. So this is really what was developed. And I'll just start off by looking at some additional data on this issue of TB rates. Now, this is a more complicated table, and I'll just kind of lead you through it because it includes two studies. Not only the one that Lauren Lambert did using the 5-year period from 2003 to 2007, but also this 7-year period from 2010 to 16 by other CDC colleagues. And the lead author is Mongkol Rathnasai, and I think I've pronounced that correctly. And so I'll just point you first to the US total rate. So these are the rates mid-year during the 5-year and the 7-year period. So 4.8 and 3.0. This middle column is among healthcare providers, 4.2, again, lower than the 4.8, and 2.5, lower than the 3.0. So overall, healthcare providers had lower rates. And again, with this, you can see within each category of US-born healthcare providers, the rate in 2003 to 7 was 1.7, had dropped to 1.8 among the non-US born from 17.9 to 10.8. And you can see again among the US born, again over here on the right, very similar pattern of the US born, foreign born populations overall. So again, it's a bit of a complicated table, but it's really meant to show that even during this second period of evaluation, the rates remain low. I'll show you just a few of the boxes and some of these. Oh, and this is a listing of the headings. This is from the beginning of the recently published article. And you can see it's got sort of every topic. And so there are work groups dealing with each of these to provide occupational health care providers with information about each issue as they address them going on. One point again, newly positive IGRs or skin test results in people where we would say this is most likely a false positive. No real exposure since the last test. The idea is don't get an x-ray now and then repeat the test. Say this is most likely a false positive. Repeat the test first. If it's negative, you can say this was a false positive you had. It's not unexpected, and you're basically have no evidence of LTBI, TB infection. Obviously, along with that is a symptom review to make sure they don't have the symptoms of TB. So, and a negative, and all this issue of getting a negative chest x-ray for hiring issues were addressed as well. This is the second part of that list of issues. And again, we won't try to go through those. I'll just show you a couple of more boxes and hopefully we'll have a little time for discussion. So the big issues are that healthcare personnel might have risks for TB exposure unrelated to work, like our nursing student, for instance. And or they may have risks for progression after the baseline that might change what they want to do about their known LTBI they decided not to have treated. So this ongoing education of healthcare providers, not only about risk factors for getting LTBI, but also for progression, is encouraged. And the decision to perform TB testing after a baseline should really be based on that individual's risk for exposure at work or elsewhere since their last test. Again, a lot of discussion, and there's even the regimens outlined, what the pills look like and so forth. And also the evaluation that needs to be done to make sure we're not giving LTBI treatment to somebody who really has active TB and we haven't evaluated it properly, and stressing the benefits of treatment as well to try to deal with TB in the US, in the healthcare providers in this country, which is really not a function of new infections occurring every year because of exposure, but because of known mostly prior latent TB infection.